Nursing 345, Breast and Regional Lymphatics. The objectives for this week include assess the composition of the breast glandular tissue, describe the ways of documenting clinical findings from a breast examination, relate the anatomy of the breast lymphatic system, cite the location of superficial groups of lymph nodes that are accessible to examination, discuss the importance of teaching testicular self-exam as health promotion during assessment, describe developmental care for examination of anal, rectal, and prostate structures, incorporate health promotion concepts when performing an assessment of the anus, rectum, and prostate, outline the changes observed during puberty, acknowledge and include health promotion concepts when performing an assessment of the genitourinary system. The breast or mammary glands are accessory reproductive organs that lie anterior to the pectoralis major and serratus anterior muscles and are located between the second and sixth ribs. They extend from the sternal margin to the mid-axillary line. The nipple is just below the center of each breast and is surrounded by areola. In the areola, Montgomery's glands secrete a protective lipid material during lactation. In the upper outer quadrant, the tail spence projects laterally into the axilla. It is the site of most breast tumors. The breast is composed of glandular, fibrous, and adipose tissue. The glandular tissue contains 15 to 20 lobes that radiate from the nipple and are composed of lobules. Each lobe empties into a duct that carries milk to the sinuses, which store milk behind the nipple. The fibrous tissue includes Cooper's ligaments that support the breast tissue. Adipose tissue houses the lobes and provides most of the bulk of the breast. To help document findings, the breast may be divided into quadrants with imaginary horizontal and vertical lines that intersect at the nipple. Findings may be described according to the clock and centimeters from the nipple. The breast has extensive lymphatic drainage, which occurs primarily through 4 groups of axillary nodes, with most lymph draining into the axillary nodes. The breast undergoes significant developmental changes. At puberty, estrogen stimulates breast changes. The breasts enlarge, the duct system grows, and masses of small solid cells develop at the duct endings. Breast development occurs in 5 stages, which are described using a sexual maturity rating scale or the Tanner staging. During pregnancy, breast changes begin in the 2nd month with expansion of the ductal system and supporting fatty tissue and the development of the true alveoli. Colostrum may be expressed after the 4th month. After menopause, secretion of estrogen and progesterone decreases, causing glandular and fatty tissue to atrophy so that the breasts droop and sag. The male breast consists of a thin disc of undeveloped tissue underlying the nipple. During adolescence, the breast tissue may enlarge, which is usually temporary. The timing of puberty is influenced by genetic and environmental factors. Obesity contributes to early onset of puberty. Breast cancer rates begin to fall after the reduction in the use of hormone replacement therapy in perimenopausal women. Lifestyle factors relate to breast cancer risk, with alcohol drinking associated with a risk in a dose-dependent measure. Additionally, the Mediterranean diet has a modest protective effect, whereas a Western diet has a modest positive association with breast cancer risk. To obtain subjective data, questions should be asked regarding breast pain, lumps, discharge, swelling, trauma, history of breast disease or surgery on the breast, the use of oral contraceptives, and the frequency of breast self-exams and the last mammogram received. Ask questions inquiring about any tenderness, lumps, swelling, or rash in the underarm area. For objective data, first inspect the breast as the woman sits. Note the general appearance and symmetry of the breast, including the color, texture, and integrity of the skin. Observe for bulging, discoloration, or edema. Assess the nipples and areola for symmetry, shape, and any abnormalities. Next, ask the woman to raise her arms overhead. Then ask her to push her hands on her hips, leaning forward. This tests for retraction. Inspect and palpate the axilla and regional lymph nodes. With the woman supine and her arms raised over her head, systematically palpate all four quadrants of the breast, including the tail fence, the nipples, and the areola. If you feel a lump or a mass, note its location, size, shape, consistency, mobility, and distinctiveness. Also notice any related nipple changes, skin changes, tenderness, or lymphadenopathy. After the assessment is complete, teach breast self-exam. Besides reviewing the appropriate technique, you need to cover additional points. Breast cancer is the second major cause of death from cancer in women. However, early detection and improved treatment have increased survival rates. The 5-year survival rate for localized breast cancer has increased from 78% in the 1940s to 98% today. If cancer has spread regionally, survival rate is 84%. Help each woman establish a regular schedule of self-care. Breast self-exam is best done right after the menstrual cycle when the breasts are the smallest and least congested. For women who are not menstruating any longer, suggest choosing a familiar date to examine her breasts each month. Review the American Cancer Society's recommendations for mammograms and clinical breast exams. For a male patient, combine the breast exam with the anterior thorax examination. Inspect the chest wall, palpate the nipple area, and palpate the axillary lymph nodes. For infants and children, in the neonate, breasts may be enlarged and visible due to maternal estrogen crossing the placenta. The breast may secrete a clear or white fluid called witch's milk. This is not significant and is resolved within a few days to a few weeks from birth. For children, note position of nipples on a pre-puberty child. They should be symmetric, just lateral to the mid-clavicular line between the fourth and fifth ribs. The nipple is flat and the areola is darker pigmented. Adolescent girl, breast development usually begins on average between 8 and 10 years. Expect some asymmetry during growth. Record stage development using Tanner staging. Use charts to teach adolescent normal development stages to assure her of her normal progress. With maturing adolescents, palpate breasts as you would with an adult. Note any mass. Teach breast self-exam now so the technique will become a natural, comfortable habit by the time the girl becomes an adult. Pregnant women, breasts increase in size, as do nipples. Delicate blue vascular pattern is visible over the breast. Jagged, linear stretch marks may develop if breasts have increased. Nipples become darker and more erectile. Areola widen to grow darker and contain small, scattered, elevated Montgomery's glands. On palpation, breasts feel more nodular, and thick yellow colostrum may be expressed after the first trimester. For lactating women, colostrum changes to milk production around the third postpartum day. Breasts may become engorged, appearing enlarged, reddened, and shiny, and feeling warm and hard. Frequent nursing helps drain ducts and sinuses and stimulate milk production. Nipple soreness is normal, appearing around 20th nursing, lasting 24 to 48 hours, then disappearing. Nipples may look red and irritated, may even crack, but will heal rapidly if kept dry and exposed to air. Frequent nursing is best treatment for nipple soreness. Aging women, on inspection, breasts look pendulous, flat, and sagging. Nipples may be retracted but can be pulled outward. On palpation, breasts feel more granular. Terminal ducts around nipple feel more prominent and stringy. Thickening of the inframammary ridge at lower breast is normal and feels more prominent with age. Reinforce value of breast self-exam. Women over 50 years of age have increased risk of breast cancer. Here's your checklist for assessment of breast and regional lymphatics. Inspect breast as a woman sits. Raise arms overhead, pushes hands on hip, and leans forward. Inspect the clavicular and infraclavicular areas. Palpate the axilla and regional lymph nodes with the women supine. Palpate the breast tissue, including tail of Spence, the nipples, and areola. Teach breast self-exam. And our last slide is our sample note. So for subjective, states no breast pain, lump, discharge, rash, swelling, or trauma. No history of breast disease herself. Does have a mother with fibrocystic disease. No history of breast surgery. Never been pregnant. Performs breast self-exam monthly. Objective, breast symmetrical, skin smooth with even color, no rashes or lesions. Arm movement shows no dimpling or retractions. No nipple discharge or no lesions. Palpation, breast is contour and consistency firm and homogeneous. No masses or tenderness. No lymphadenopathy.